So what we're going to talk about today is evaluation and management services with a specific focus on podiatry. The first thing that we have is our disclaimer, and we provide this education as a tool for you to use. Now, Medicare rules, and you know this if you've been with Medicare any length of time, Medicare rules do change, and they can change often depending on what CMS does. The CMS laws, regulations, and rulings determine the final determine coverage of services that you're providing. As I stated, we will provide responses to your questions either on the webinar today or through an email following the webinar. And then the last information there, CMS does prohibit recording of this presentation for profit-making purposes. I'm recording this, and we will have this available, barring any technical difficulties with the recording. We will have this available on our Encore page on the WPSGHA.com website, and then also on our YouTube channel. So let's talk about our agenda and our objective today. Well, our objective is we want you to have the information about evaluation and management services so that you're billing appropriately to Medicare. Medicare's job, WPSGHA, as your Medicare administrative contractor, our job is to pay you appropriately for your services. So if you're understanding the rules and regulations, that means that you can bill Medicare correctly for your service, we can process it correctly, and then you get your payment back faster. We're going to go into how to choose your level of service, and we're going to discuss the Medicare rules for both office services and then nursing home services. These are the most common areas where podiatrists are providing the E&M services. We did have a pre-submitted question that we'll kind of just throw in here. And the question was, can a podiatrist treat the patient for services above the ankle? For Medicare purposes, podiatrists generally can treat the foot and ankle. Now, in Michigan, I know a podiatrist, if they follow the state requirements, can also treat the hands. You want to check with your states to determine how their license works and what you can actually treat based on their requirements. These are the acronyms that we're going to be going through today. I like to kind of gather them all up in one spot for you so you can have these as a reference. So when talking about evaluation and management services, the very first question that your documentation needs to support is the medical necessity of the service. You can see from the Social Security Act, services do have to be reasonable and necessary. And so if you look at the section 1A, it says, and it's talking about payment, services have to be reasonable and necessary for the diagnosis or treatment of an illness or injury or to improve the functioning of a malformed body member. So this is all based on your documentation. What are you doing for the patient? Why does the patient need your services for this encounter? When the Medicare Administrative Contractor's medical review staff, the Comprehensive Error Rate Testing Program, or other review contractors with Medicare, this is the first thing that they're going to be looking for. What is the medical necessity for the service? Excuse me. The next thing that we have is what Medicare considers to be the same physician. The same physician is going to mean the same person. So Dr. Smith is always Dr. Smith, or members of the same group. Now that's going to be the tax ID under which those providers are billing when they have the same specialty. So two podiatrists in one group are going to be considered the same person by Medicare. This will apply to possibly multiple evaluation and management services on the same day. Global surgery package, there are several things that this applies to. If, however, the specialties are different, or they're not part of the same group, then Medicare would consider them to be different people. And so some of these rules would not apply. We have procedures that happen or could happen on the same date as your evaluation and management service. And there are modifiers if you meet an exception. Evaluation and management is built into the reimbursement for the surgical code, and therefore we would not pay a separate E&M on the same date as a procedure unless these exceptions apply. Now, on Tuesday, May 14th of this week, we held a podiatrist and global surgery webinar. This will be available on our YouTube channel and our encore page probably sometime within the next week. We did just add a specific playlist for podiatry. In fact, we just added that yesterday. So the podiatry webinars that we have held this month are all going to be within that playlist. If there are other topics that you would like us to cover, you want to place that information within your survey. If there are particular procedure codes you want us to do education on, particular circumstances geared toward podiatry, then let us know that and we'll be happy to take a look at that. So what you have up on your screen are modifiers 25, which is a significant separately identifiable E&M on the same day as your procedure. Those words are very important. Significant means a great amount of additional work. Separately identifiable means that a reviewer looking at your documentation can tell this is the E&M that is part of the surgical procedure. This is E&M that is not. You need to make sure that your documentation supports that. Modifier 24 is an unrelated E&M service during that global period. So that's following the procedure. This is diagnosis based. You did the particular procedure because of a wound. Now you're doing an evaluation and management service for the patient that has pain in the other foot. Then that's unrelated, so you could use modifier 24. You also have modifier 57, which is a decision for major surgery, which is a 90-day post-op on the day of or the day before the surgery. And then, of course, documentation must support that. Evaluation and management services are a per diem service. So we pay for one per day by that same provider or a member of the same group with the same specialty. If you have more services that you're providing to that patient within that same day, then you want to look at possibly using time to choose your level of service. You can also then look at the prolonged care codes if they're appropriate for the amount of time that you have spent. Multiple physicians, again, this goes back to same physician, same group, same specialty is the same provider. If you have, if that does not apply, then these rules that we have talked about so far also do not apply. The next thing that we'll show you is the American Medical Association really owns the procedure codes and the descriptions of these codes. As you can see there on your slide, they made some major changes to the descriptions in 2021 for office or other outpatient services, and then in 2023 for all the other categories of services. When you're choosing your level of service, you're going to choose that based on either time or the medical decision making. You can see there are two exceptions. Any services provided in the emergency department are medical decision-making only. Services provided in the critical care unit are going to be time-based only. So when we talk about the categories of medical decision-making, there are three: number and complexity of problems that you are addressing during that encounter, amount and complexity of data to be reviewed, and then the risk to that patient from the treatment decisions that you are making for that patient. A biller or coder is probably not going to be able to choose this one unless the physician has really documented that very well. The practitioner should be assessing that patient for the level of risk based on their medical decision making. And then you can see at the bottom, in order to choose your specific procedure code, you have to meet the requirements for 2 out of these 3. Excuse me. So the information we are showing you on your screen now is from the AMA. This is on their website. This information is also contained within the CPT book, and it provides you with a description of each of the different levels of a problem. So for an example, for the straightforward, you can see it's a self-limited or minor problem. When you get into the moderate, it could be one or more chronic illnesses with an exacerbation. When we're talking about chronic, we're talking the patient either has had or you expect them to have whatever that illness is for at least 12 months. Now, we know that in providing education on E&M, some providers don't use the 12 months, they use 3 months, 6 months, etc. The AMA has defined chronic, however, as 12 months, and the Centers for Disease and Control have also defined it as 12 months. So that's what we're going to be expecting to see within your documentation. In addition to that, you can see under the moderate, you have 2 or more stable chronic illnesses. Well, the definition of stable means that patient is at your goal. Whatever disease or illness you're dealing with, that you have decided this is where I want my patient to be, and therefore this is where they are. That's the definition of stable. If they're not stable, then they fall into that illness with exacerbation or progression or side effects of treatment, etc. And then if you look at high, the first one there, 1 or more chronic illnesses with severe exacerbation. The difference between the high and the moderate is going to be based on the documentation and how your physician or practitioner is identifying that this is a severe exacerbation as opposed to simply an exacerbation of that problem. You also have under the moderate, you have an undiagnosed new problem with uncertain prognosis. Now, providers seem to be a little confused on this one. Number one, it is an undiagnosed new problem. So that means that the patient does not already have it. So for an example, if the patient is coming to you and they have severe foot pain and they've had that for the last 3 years, for an example, this is now a new patient to you. It's not an undiagnosed new problem. So it's, when we're talking about that, we're talking new to the patient, not new to you. And then we also have to include those other 3 words with uncertain prognosis, meaning that you don't know for sure yet how this is going to affect that patient. Whether it's going to be a situation where eventually you may have to do an amputation, for an example, or you simply don't know yet what that prognosis is going to be. It could turn out to be something not necessarily very serious. So we have provided you here the CPT definition of a problem. So you can read the language there. This could be a patient stating, I have foot pain. You don't necessarily know what's causing that yet, but that's what they're presenting to you. It could also be an ongoing disease that you're dealing with, such as neuropathy for the patient's foot. The problem really, and how you are identifying the problem really kind of determines the medical necessity of the service. And then it also helps you to define your level. You'll notice on here also that it indicates addressed. So when we're looking at a problem that has been addressed, it means that you're evaluating or treating that problem during that encounter. Now, we know for Medicare beneficiaries, generally these are patients who are over age 65, or it's patients who are on disability for some reason. They can have a lot of diagnoses. As a podiatrist treating the patient's foot, providing the patient's foot care, the patient can also have a lot of diagnoses that you're not actually treating. So what you want to look at here in this list of diagnoses and the definition of addressed is when you have to use that information from the other diagnoses that maybe you're not treating in order to determine your treatment plan for that patient. So the documentation here is really needs to show how your physician or practitioner has addressed that particular problem. This is really the proof of thought. That's a terminology that one of our contractor medical directors uses. And that's what the documentation should show, what your physicians or practitioners, how they're thinking about the problems that the patient has, how they're addressing those problems, how they're managing those problems in doing that treatment for the patient. The next thing that we have here is the data, and you'll notice here that these are divided into categories. So you have the limited, you have moderate, and then you have extensive. If you'll notice on the limited, you have the two categories, tests and documents, and we'll talk about that in just a second. And then category 2, assessment requiring an independent historian. When you move into the moderate, notice that that category 2 has now moved into category 1, and now you have independent interpretation, and then category 3, discussion of management. And we'll talk about these in more detail. So the categories then, you have to meet whatever requirements are there. The straightforward has minimal or none. For the low level, you have the two different categories to choose from. This includes under tests and documents, you have to have 2 of the items that were listed. This includes reviewing a test, reviewing notes from a unique source, ordering unique tests, etc. And then category 2 is the independent historian for the low level. Now, an independent historian means that you can't trust what the patient is telling you. And that could be for many different reasons. It could be dementia. For some reason, it could be that, the patient is not remembering what happened. It could be a lot of different things. So this is where you need someone else to provide you with that additional history. And then, of course, you'll document that within your records to show why you needed that and then what that independent historian told you. Then we get into the moderate, where we have to have 1 out of the 3, and then high, which is 2 out of the 3. When you're talking about the test category, we're ordering tests, we're reviewing tests, we're looking at documentation from a unique source. So let's think about that for a second. If you're ordering a test, Medicare expects you to review that same test and to use that information in your treatment of the patient. So a test that you order today, you don't count that separate review. If you ordered a test, maybe from the patient called in, had some type of problem, you ordered a test, and you're now reviewing that test in this evaluation and management, you can count that as long as you have not counted that order somewhere else. If you're looking at reviewing information from unique sources, so that could be that you're looking at documentation from another physician, as an example, a previous ER visit, something along that lines. So data analyzed, and you can look at the actual definition there, but this again goes back to proof of thought. Why do you need this information, and what are your physicians and practitioners going to do with this information? We have tests that are defined here: imaging, laboratory, psychometric, physiological data, etc. You can also see on here that pulse oximetry, per the AMA guidelines, is not considered a test. For the category 2, for moderate and high, this includes an independent interpretation. And this is similar to what maybe a radiologist or a pathologist would do for that test. You're looking at the x-ray or the slide, and you're preparing an interpretive report in your documentation. You're deciding what that test result actually is. This is above simply a review of the test, and then you make your decision, or a review of the report from that other provider and then making that decision. The AMA also defines unique and what is considered a unique test. And for testing itself, this is basically your procedure code. You order a urinalysis, for an example. Well, that's one procedure code. You order a CBC, that's one procedure code. If you order a lab panel, then the testing that would go into that lab panel, that would be considered one unique test. If you're reviewing records, you look at the unique source. So for an example, if you're reviewing records from Dr. Smith from the last 3 visits the patient had to Dr. Smith, that's one unique source. If you're reviewing testing that Dr. Smith did, then that's a unique test that you're reviewing. So you can count both of those when you're counting this for your categories. Another thing that the AMA defines is a discussion, and this is part of category 3. This is a real-time discussion between practitioners. You can see on here that it shows an interactive exchange. So this could be a conversation you're having with another practitioner. It could be text messaging, emailing back and forth, etc. Chart notes do not qualify as an interactive exchange. Now, it doesn't necessarily have to happen on the same day as that encounter, but you're only going to count it once, and only when it's used in the decision making for that encounter. So, if you start a text message or a chat message or something like that with that other practitioner, and you're going back and forth for a couple of days, in order to count this, you have to wait until that exchange is completed and you're using that information within your medical decision making, and then you can count it for that encounter. Otherwise, if it happens afterward and you've already billed the service, then you would not count it. The next thing that we have is risk of complications. And this is the risk to your patient from the medical decision makings that you have. And we'll talk about some of the definitions in the next slide. Coders and billers are having a really difficult time with this one because the providers, that your physicians and practitioners, are not defining the risk. They've got information in there, but your coders and billers really can't define that risk. The information that's up on your screen right now are simply examples. And specifically what I mean by that is that you could have prescription drug management, but it's really not a moderate risk because the rest of the documentation does not support that. You could also have a situation where none of the examples that are listed here apply to your patient, but based on your documentation, then that patient could fall into high risk. So these are examples, they're not absolutes. So let's talk then about the risk and the definition of the risk. It's up there on the slide for you. And so what we're talking about here is the probability and or consequences of an event. So for an example, if you're going to order, let's say a CT scan of that patient's foot, and you're going to use contrast. Well, what's the risk to that patient from having that test and then having that contrast material? That's what the documentation will need to show. You could have patients with a stable chronic condition and you renew that patient's prescription. What's the actual risk to that patient for this medication that they have been on, for several years? This also goes back to proof of thought. What's the probability or consequences of the medical decision making that you're doing for the patient at the time of that encounter? Prescription drug management seems to be the ones that are the one we have the most questions on. This does not include drugs that you may administer to the patient through an injection at the time of the encounter. This is going to be prescription medication. It could also be managing over-the-counter medication when that over-the-counter medication can provide a risk to that patient. So again, what you want to look at is if I'm deciding that my patient is going to either continue taking this medication or start this new medication, what is the risk to that patient from that medication itself, from that decision that I have made? Social determinants of health. These are economical and social conditions that may influence how your physicians and practitioners are making their medical determinations. This could include food insecurity, housing insecurity, etc. Now, this is, as part of your E&M service, you can be providing a screening. A screening is part of your E&M. If based on that screening, however, the patient has identified an SDOH risk that's going to affect how you're going to treat them, there is a separately billable procedure code for that, and that's listed up there for you on the slide. We did provide a webinar on this, and Aline is going to place the link to that webinar YouTube video in the chat function. So this could be an example where the patient maybe has diabetes and you've provided them with great information on nutrition, but the patient has food insecurity. They live in a food desert where they can't get to the really good foods that they need to have. Well, then how is that going to change your plan? It could be a situation where you're telling the patient that they need to keep their foot elevated to assist in the wound healing, but the patient doesn't have a home. So how are they going to accomplish that? And then using that information to adjust that plan then allows you to build that G code that's listed on your slide. The next thing that we talk about then is using time to choose your level of service. When you're looking at time, it's going to be time as identified within the code, and it's generally a range that's in there. And so you would have to meet at least the minimal amount that is in that code range. It has to happen all on the same calendar date, and it can include both face-to-face and non-face-to-face time, which I'll show you some of those activities in a minute. Your physicians need to be documenting the specific time that they're working for that patient. You really want to pay attention to these non-face-to-face activities. Don't leave money on the table. If you're going to choose your procedure code based on time, make sure your physicians and practitioners are documenting this. Preparing to see the patient. You're reviewing lab tests from tests that you ordered previously so that you can talk appropriately about those services. You need to obtain separate history, and so you're having a conversation with the patient's daughter or their spouse. That time is counted as long as you have it documenting. And then performing the appropriate exam, and then counseling or education you can see there. Another thing that you have listed on this slide, and I'm not going to go through all of them, but look at that third bullet point. If your physician or practitioner is entering information into that health record, count that time. That also is part of the time that your physician is spending working on that patient. You don't count the time for the things listed on this slide, such as travel, other services that may be separately reported, etc. Excuse me. So now we're going to switch gears here just a little bit, and we're going to talk about office services. You can see your range of procedure codes listed there. You can see your in-person places of service listed, and then also your telehealth places of service listed. Just as an FYI, for the place of service code 10 for a patient's home, they don't actually have to be in their home if they're in the driveway because they don't want their other family members to be part of the conversation. If they're in the local McDonald's so they can use their Wi-Fi, that still counts as the patient's home. A new patient is going to be a person who has received no other professional services within the preceding 3 years. And again, it goes back to the CMS definition of that same person. So you're a podiatrist within your group, you're seeing the patient the first time today, but the patient saw another podiatrist within your group within that previous 3 years. That's when you're going to submit an established patient procedure code, not the new patient procedure code. This tends to be a bigger issue for non-physician practitioners. CMS states that a non-physician practitioner, such as a nurse practitioner, physician assistant, etc., they have their own specialty, which means a nurse practitioner is going to bump up against another nurse practitioner. A nurse practitioner is not going to bump up against your podiatrist. Evaluation and management is part of an administration of a drug. So if you're doing an IM injection, an IV, a sub-Q, something along those lines, then in order to bill separately for that E&M, you would have to meet the modifier 25 guidelines, significant amount of additional work, and then separately identifiable. Another consideration for you within your office is going to be the National Correct Coding Initiative edits. What I'm showing you up on the screen here is actually a picture from the procedure to procedure edits themselves. In the column 1 location on here, or column A, it has the payable procedure code. Column 2 is the procedure code that goes into column 1. The next column that you have there, column C, will give you information if the code has been part of the coding edit for a long time. It will give you a date there. And then you have columns D and E, which is the start and an end date of the coding combination. And then column F, the next column over, tells you whether or not a modifier would apply. The 1 means a modifier would apply, the 0 means that it would not, meaning that it's simply not going to be payable separately. And then the next column that you have is the reason behind why this is a procedure to procedure edit. So the first chart that you have is when an E&M is the column 2 code. So that would be the denied code unless a modifier would apply and your documentation supports it. The second chart that you have is where your E&M service can be the payable procedure code, but then there are other procedure codes that would feed into that E&M, and again, not separately payable unless a modifier would apply to that. We also have information for you here on incident 2. The first thing that you need to look at there is that it is in place of service 11. Place of service codes 19 and 22, which are outpatient hospital locations. Incident 2 does not apply there. There has to be an employment relationship between the parties. This can be a W-2 employee, it can be a leased employee, a contracted employee, etc. The service is incident to your plan of care. So they're simply following your guidelines and your direction, your medical decision making for that patient. If for some reason this is being provided by a non-physician practitioner, if they change that plan of care, then it's no longer incident 2, and you would need to bill under that non-physician practitioner. They also have to be located within the same office suite. One of our previous contractor medical directors identified this as speaking loudly distance, so that, you know, they can provide immediate assistance should you need, should your non-physician practitioner or your ancillary staff then need to know that. One of the things that we've heard over the years is that the office did not enroll their non-physician practitioners. I can tell you that's incorrect. You do need to enroll them. You will have those situations where the NPP starts out thinking that they're going to provide an incident 2, and then the patient says, oh, by the way, just as they're leaving or trying to leave the room. So you do want to make sure your NPPs are all enrolled. The next information that you have there is on prolonged care services within an office setting. You can see the procedure code there, the G2212, and then it gives you the procedure codes themselves and then the time that is required for reporting. So you can see there, number 1, if you're going to use prolonged care services, you have to be choosing your level of service based on time. If you're choosing your level of service based on the medical decision making, then prolonged care does not apply. So you would only use this with the 99205 or the 99215 procedure code. And this chart shows you that if you have 60 to 74 minutes, then you simply have the 99205 procedure code. In order to build the G2212 code, you have to have at least 89 minutes and the full 15 minutes in order to build that. So you can see there that if you're within that 89 to 103 range, then you can bill that G2212. We also have information for you about the add-on complexity code, and we just finished not too long ago a webinar on that. And then Aline will place the link to that YouTube video within the chat. For the add-on complexity, in order to bill for this service, you have to have a longitudinal relationship with that patient, meaning that this is going to be a long-term relationship with the patient. And there are two ways that this can be applied. Number one is that you're the focal point for the patient's health care. Now, as a podiatry specialty, you're not going to qualify for that one. You may, however, qualify for the second definition of that, which is that you are taking care of, again, that longitudinal relationship for that patient for a single serious condition or a complex condition. And your documentation will need to support that. As part of using this procedure code, your documentation will need to support your coordination with other providers that patient may be seeing. And then there's a lot of additional information within that webinar. And then the last bullet point there, if you're doing procedures and on the same day and you're a pending modifier 25, then you would not be billing this add-on complexity. That's one of the rules by CMS. We have the definition for you here that you can take a look at. We talk about the relationship with that patient, and again, it is a longitudinal relationship. Now, this procedure code can be billed on a new patient procedure code, but your documentation will then need to show that you're anticipating that this is going to be a long-term relationship for that patient's single serious condition or a complex condition. For your telehealth services right now, through the end of 2024, there are no geographic restrictions. This is provisional for evaluation and management. For treatment of behavioral or mental health, this is considered permanent. CMS maintains the list, and it also lets you know if you can do this audio only. What we have up on your slide is just a picture of a portion of that list. You can see it lists the procedure code, the short descriptor, and then it will show you whether or not you can do this audio only. And then the category is either going to be provisional or permanent. Provisional means through right now, through the end of 2024. Permanent means that it will continue on after that. For any of those that are provisional, we will need to watch the final rule for 2025 to see what CMS is going to do. For your technology, you do have to have a platform that will do audio video. Even if you're doing the service audio, you still need to be able to do both audio and video. The practitioner needs to be able to do that. It does need to be HIPAA compliant so that it is a secure site. And then, of course, the patient has to consent for that. The distant site practitioner, this is going to be the location of your physician or practitioner providing the service. So if your practitioner is in Florida, you're going to bill Florida, the Florida Medicare contractor, for that service. The site of the physician determines the MAC, even if the patient is in their home. Where that physician is located determines where you bill, and that includes the physician's home. You want to look at any state guidelines for license information if you're providing to a patient located in another state. For the patient location, again, we've talked about this one. There's no geographic restrictions for 2024. And then we have the place of service codes listed for you there. Now, the last 3 bullet points, if your physician or your non-physician practitioner is in a hospital setting, when the patient's in their home, they're going to, instead of using 10 through the end of 2024, they'll use the 19, 22, or 21, and then submit that modifier 95. The next information that we have for you is on nursing facility services, and we've provided you with a list of the locations, the place of service codes. The CPT does include an additional high-level problem for the medical decision-making that is specific to the initial nursing facility care. So you can take a look at this one. More than likely, podiatrists are not, this one would not apply to you. However, take a look at the definition and your documentation itself. We have initial care codes, which are the first time, excuse me, the first time that your practitioner is seeing the patient during that stay. Now, you'll notice in that second bullet point, a change in the status does not indicate a new stay. And so what we mean by that is if the physician, or I'm sorry, the patient moves from nursing facility to skilled nursing facility, but they're still in the same place, you would have a subsequent visit the next time you saw them. The admitting physician is going to use that modifier AI. If you're not, the admitting physician, then you can still build that new patient procedure code. Subsequent services are when that practitioner or a member of the same group with the same specialty has already seen that patient. And then the bullet point that says subsequent care codes must stand alone. That means that your documentation has to support that service you're providing today. It's not just the fact that the patient is in a skilled nursing facility. It's not just the fact that the facility has asked your practitioner to come in and do a foot care exam on all patients. Medicare would probably not pay for all of those. What is the specific medical necessity for your service today? And then we have information on the prolonged care services. Now you'll notice on this one, number one, there's an additional procedure code there. You do still have to meet the full 15 minutes before you can do this code. However, it's 1 day before the date of service and up to 3 days after. So this one gets a little different. Your procedure code, for an example, the 99306, that total time has to be on the date of the encounter. Your prolonged care time, however, could be 1 day before or 3 days after the date of the encounter itself. Split and shared requirements do apply when a patient is in a skilled nursing facility only. Providers are considered part of the same group, and you'll submit under the practitioner that has provided the substantive portion of that service. We are getting ready to do in June a presentation on split and shared services that has been advertised on our website, and you can certainly take a look at that. Incident 2 services can apply to your nursing facility patients, but all of that same requirements that we talked about have to be met. Speaking loudly, distance, employee of the practitioner, not the facility, etc. You can also have an office within your facility, but it does have to be a designated office. And any staff that you have within that office are your staff, and they can only provide services within that designated area. Any ancillary care provided outside of that designated area is simply part of the facility charge. We provided you with the place of service codes here for home. If you're going to see that patient in their home, the patient does not have to be homebound in order to receive services in their home. This could be a convenience for the patient or for the provider, either one. To determine patient status in the patient's home, that's the same rule as what we talked about with the office. If they've not been seen by you or a member of your group within the previous 3 years, they can be new. Otherwise, then they would be subsequent patients. The next several slides that we have for you are your resources. We provided you with Social Security Act, with information on the Code of Federal Regulations, within the Internet-only manuals published by CMS. And then we've also provided you with an MLN on the Evaluation and Management Service Guide by CMS, and then information from the AMA website on their changes for 2021 and 2023. We provided you with links for the relative value file, Medicare Physician Fee Schedule relative value file. That's where you can find your global surgery days for any procedures that you're doing. And then we provided you information on the procedure to procedure edits, the policy manual, and then also the list of telehealth services. So the next thing that we have is questions, and we did receive some pre-submitted questions. And with the time that we have left, I'm going to go over those. Any question you have submitted within the chat, we will be developing a document that we'll send back to our attendees that will show the question, and then we'll show the answer. So one of our pre-submitted questions is, can you submit a routine foot exam as an evaluation and management on the same day as doing a debridement? Well, first, a routine foot exam itself is not an evaluation and management. Excuse me, it can be part of one. In addition, if you're providing that E&M on the same day as, as the debridement, then you would need to evaluate your documentation for the possible use of modifier 25. The next pre-submitted question that we have is, are podiatrists limited in the level of E&M service that they can submit? And the answer to that is no. Just like any other practitioner, you would have to meet the guidelines, the AMA and CPT guidelines, on choosing your level of service. Now, for podiatry, the lower level services are the most common, but that does not mean that you're simply restricted to those. And then the last pre-submitted question we had is talking about procedure code G0425. This is a telehealth consultation. This is where your practitioner would be providing a consultation, a requested consultation, to a patient, generally is going to be in a facility through telehealth as opposed to in person. So in order to appropriately bill that procedure code, you would have to meet all of the telehealth guidelines and would have to meet all of the consultation guidelines. So that, I realize that's a lot of information that we provided for you here today. Again, we have recorded this presentation. Within a week or so, it will be available on our Encore and in our YouTube channel. The questions that you have placed in the chat, we will provide responses back for you. So on behalf of Aline and myself, we just want to thank you very much for your attendance today. We hope that you have enjoyed this presentation and are able to take this information back into your practices. We do again encourage you to take that survey. We pay attention to that. It's important for our reporting. It's also important to our specialist. You know, we take a look at that to see what we can improve upon in our presentations, etc. So again, we just want to thank you for attending, and you can now disconnect. Have a great day, everyone.